Or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of BBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by Beacon Health, and it is titled AI Native Primary Care, Tactics to Thrive in Value-Based Care. Today's session is going to be a little bit different than what we do. It's going to be kind of more of a conversational format, kind of a fireside chat with our speakers, who I will introduce in just a moment, and they'll be discussing some pre-prepared questions on the topic at hand. But a few items of note before we get started. Everyone is joined today in a traditional format, like a webinar format, to where we can't hear you or see you, but we do want to hear from you, and we are going to have a time for some Q&A towards the end, some audience Q&A. We've got a lot of stuff to cover. We've got a lot of discussion to have. So we may not be able to get to all the questions that are submitted, but if we don't get to yours for some reason, don't worry, someone will reach out to make sure that we get your question answered via email. Also, the session today is being recorded, and so what's going to happen is when we conclude, maybe about an hour or so afterwards, you will receive an email that will have a link to the recording, as well as to the few slides that we do have. You'll be able to get those as well. So at this time, I'm going to turn it over to Mark Pothin. He is the CEO of Beacon Health, and he's going to introduce our speakers today. So welcome, Mark.
Howdy, friends. I'm Mark, and I'm the founder and CEO of Beacon Health. And so today we have two awesome people that I love very dearly, Karthik and Jenny, and I'll kind of let them introduce themselves. I mean, like, what they do speaks for themselves. So Karthik, go ahead. Tell me about yourself, man.
I'm Karthik Ravindran. I'm an internist by training, primary care doctor. I have my own private practice in the Metro Boston area. I'm also the CMO for Beacon Health. My private practice is part of a IPA centered around geography that's probably 20 miles west of Boston, and that plugs into a larger system, which Dr. Chiang is a part of. Prior to that, I was the National Medical Director for Population Health for Carbon Health, and I was an employed primary care doctor in an academic system, the Tufts Medical Center systems.
Jenny, tell us about yourself.
Hi, everyone. I'm Jenny Chiang. I am a board-certified family medicine and geriatric doctor by training, and I currently work at Tufts Medicine. But you can see that the IPA that Karthik had referenced is actually I was the CEO of that IPA outside of the Boston area, and looking forward to the conversation today.
Totally. And so I think maybe just to give you guys some context on what we want to talk about. I think first it's like Jenny, Karthik, and I actually just also some context. Like I think all three of us have a lot of thoughts about this particular topic, and the like inspiration to do it in this particular way as a webinar was off the back of just like random conversations that we would end up having. We're like, oh, I think Jenny and Karthik actually want to do a podcast at once, and I was like, man, when Garrett originally asked like, oh well, what do you want to do for this webinar? I was like, man, it'd be kind of awesome to get Karthik on, and then Karthik was like, oh, we should get Jenny on as well. And we'll all just kind of like walk through kind of what like the actual big and hairy problems are, especially when it comes to like value-based care generally. Because I think this is not an argument about, well, value-based care, should we have it, should we not have it? Like, how does AI enable it? It's more that like this exists already. What are like the problems on the ground today, both from like a practice perspective and a system perspective? What are like the ways that we think not only I can make these things more efficient, but also change the paradigm around how we solve some of these problems? And lastly, like, what is the vision of the future? Like, what does the AI native practice look like? What does like AI native primary care look like? Because I think right now there's a lot of countervailing theories about what the next 5 years in primary care look like, and we'll go through a lot of that. And so I'm going to stop sharing my screen really quickly and kind of open with the first question, which is like, we had a lot of conversation about this, but like, what are the bigger and hairier problems right now that like you guys see, both from like Karthik's perspective and Jenny's perspective? And I'll just kind of like let you guys do your thing.
Do you want me to jump in?
Yeah. Karthik, why don't you go ahead?
Like that way we can kind of go from the micro up to the macro, right? From the practice level to the system level. So what are the problems? I mean, that's a hard thing to narrow down. I mean, that's like looking outside my yard and like picking out the leaf that annoys me the most that I need to rake up, because there is so much.
Charlie's like, all of them annoy me. Like,
That's part of it. But I think, and I just want to take 1 second to kind of like the thing that overarching annoys is this. So value-based care is sort of this pasture that exists. It's that city on the hill that Reagan talked about, right? Like it exists out there in the distance. What we've done with all these metrics is sort of create this path by which we shuttle our practices and our providers to be able to provide that value-based care. So if I'm cattle, and I don't mean it in that way, but that's the only analogy that can come off the top of my head, but is I am, in order to get patients the care that we all agree they need, like low cost, high efficiency, things that give patients meaning and joy, and me as a provider meaning and joy, that's the pasture. But to do that, we create these metrics, we have these quality gaps, we have these care gaps, efficiencies, and that's how we try to iterate ourselves there. The issue that happens is in that process, it creates a lot of, it makes you a little claustrophobic. So what ends up happening is, on a day-to-day basis, what's overarchingly frustrating is that it can feel, when I go see my patients after this talk, that my day-to-day is I have my face in the butt of another cow, and there's another cow behind me that has their butt in my face, or the other way around, right? So you lose track of it. You see glimpses of it, like when you have those moments with those patients, but you lose track of what is the greater picture. You can't. It's hard to see the pasture, and that is how so we want to. That is the origin frustration. So then every ask that is necessary to get there feels like, it can feel like a burden when you're on the ground. Like I understand it from a level up that this is necessary, but it can feel like a burden. And how do we redefine that in such a way? And I mean, there's numerous pain points, like I said. I mean, the one that I've been dealing with this morning is, it's a prior authorization for, a patient for one of these GLP-1s, right? He's medically indicated. There's a lot of reasons for it. I've documented to the wazoo, and it's gone back and forth a bunch of times because somebody is saying that he needs to have the diabetic version, even though he's not diabetic, and I can't make heads or tails of it. So I'm just wasting a lot of time. And the patient's frustrated. He's messaged me twice in the last week, and I just want to prescribe the med, see him in 4 weeks, figure out what's going on. I'm spinning my wheels, and now after this meeting, I'll have to go in and try to figure it out. That's frustrating, right? And that gets in the way of their care. So then I get frustrated because it feels like I need to move forward, but then there's something that's preventing me from. And the reason it's there is to reduce costs, right? Like I'm not just willy-nilly prescribing, Zepbounds for people with a BMI of 18. I'm, to help keep us, the thought is to keep us thoughtful about it clinically. And what's end up happening is it's creating a frustration. So it's hard to say just one thing, but there is numerous things like that, unfortunately.
No, totally. And I think it's it is the vision of the thing versus the actual practical application of the thing, which can lead to a lot of friction between those two worlds. And so Jenny, I think that we kind of talk a little about the lenses by which we should view this. And so I'll let you kind of take off there.
Yeah, and I just acknowledging the audience here, this is the dynamic that we have, and we spend hours with Karthik's amazing analogy. And I think the frustration that you hear Karthik talking about is at every level of the system, and sometimes it's hard to really connect to why we're doing what we're doing. I would say when people ask me what I do for work, I say population health. And oftentimes that actually, it intersects with value-based care, but it's not the same thing. So population health being that we want to take care of populations and ensure that the entire population is healthy. However you decide to segment that population, whether in the health equity world, it's by gender or by race, or it's by disease process, how do you start closing gaps so that we get everybody healthier? Value-based care is really the economic framework that sort of overlays population health. And I think that it's really like the guardrails that drive our ability to actually do population health, right? And the problem with the guardrails is that they are determined by not the provider for most, unless you are the payer and the provider. So we end up playing in this. So the space is that the constraints and the guardrails are defined by the payer, which aren't always consistent over time. CMS wants to do one thing, national payers want to do another thing. And so when we frame what we're doing, Mark, you and I sort of put it out that like, there are what Karthik has talked about, the metrics, like the outcomes in this framework. Like the financial model has often what we refer to as quality metrics, right? Like the colonoscopies and the osteoporosis metric with fractures and follow up within 7 days after discharge. Those are the sort of predefined KPIs and metrics that are imposed upon your ACO or your whatever contractual performance. Then you have so that's sort of one bucket for framing. The second bucket is actually the total cost of care, which is really where the metrics come from. I don't know that we know that there's a direct correlation that actually like making sure everybody's screened for colonoscopy decreases your total cost of care. I think we do it because it's the right thing to do. But everything that is in that bucket of controlling the cost of care is what sort of drives down those, like, now we have to do risk adjustment, right? The whole purpose of doing risk adjustment is trying to understand how much the patient's going to cost. And then the third bucket I think of as what are those processes and workflows that we need in place that Karthik has to deal with, right? The prior authorizations and all of the steps and the hurdles we have to go through to make the system work to get us to address those first two. So I'm not going to put I'm not going to say this is the most frustrating thing, but this is the framework that leads to all the frustrations. And this is what we've built. And from a health system standpoint, I can tell you when I have CMS metrics, I have Blue Cross Blue Shield metrics, I have national Optum, United Healthcare, and doctors just want to take care of the patient in front of them. So how do we then, what are the processes in place to actually like ensure that we're hitting all of those metrics in those guardrails for each of those payers, but take care of the whole population? And so I think that's where a lot of the frustration stems from.
And there's also this paradox of care. So the patients that have the most need, right? So the ones that have their A1Cs off the charts, they haven't done their mammograms, they haven't done their colonoscopies, they have 7,000 risk gaps that I haven't addressed. They don't come to see me very often because they can't make it to the office because they have a social determinant, they can't get their ride in. So I don't even code it. So then now I somehow magically get them into the office that, it's November, it's close to the end of the year. I got to get everything. I got all these screenings done, blah, 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 blah. I got to order all these tests. I've got to get, 150 codes in. And somehow in that, 20 minutes somewhere, I'm actually going to engage with them as a human being, talk to them, connect with them, understand what the problem is, try to address it, get them the right care. The concept of it being like a Hail Mary pass for that person, like that one opportunity for me to like throw it downfield, and being like a short, unathletic person, like it's not going to go more than 10 yards. That's inherently a problem. That type of patient, that is where I get the most satisfaction when we can move the needle. But to really move the needle for that patient, we have to shift the paradigm. Like that person needs a West Coast offense. They need a couple of short passes that's going to open up the field, get you down to the end zone. And it's difficult the way it's constructed currently. And so how do we create a system that allows us to run constantly outside to basically move the needle, engage that patient throughout their experience, so that we can actually, we don't have to do everything in that one shot. And that's my one crack at this person right before the end of the year.
Right. Well, and so maybe like an additional follow-up question, you kind of framed out like where the friction is overall for like both from the practices and from the health system angle. It's like, and what is like today, let's say like in the last 5 years, what have been usually the ways to try to solve these problems, and what have been the problems that arise with that? So like Karthik, for example, mentioned, well, okay, like magically, if I'm able to get this patient in, let's say that like we found out somehow through like whatever population health management platform that we like, this patient didn't have an AWV yet. They have all of these risk codes that like, and also they have all these quality gaps. How do I like get them in? And magically, maybe I get them in, and maybe I'm able to complete all this stuff. So like, say more about today, what is being done? I'm not even saying the solution. What is like actually being done from both perspectives, and the problems that end up inevitably rising from that.
I mean, I can, Jenny, if you don't mind, just let me start from the
No,
bottom.
please.
But, you know, the same way we've been doing it for, I mean, as long as I've been practicing 10, 15 years now, is we get a list. I use that list to then determine what they need to do, and I try to do as much as I can. But I become, and that visit becomes the choke point to actually do all the stuff we need to do, right? Like, you don't want there to be one, you know, you can have all these things and it funnels into this one person, this one interaction where everything has to be captured. That doesn't do the patient any good. Like, we're not caring for the patient the way, you know, we're not getting into the pasture. We're not, you know, finding out the hurdles and then addressing those hurdles. We're just saying, hey, do this and then hope for the best. We're rolling the dice. And that, you know, that becomes difficult because I have a list that I have to get through. I mean, there's a list, especially at the end of the year, it becomes a, you know, pretty hefty list there. And I think that also pushes and they can only do so much. And so then if you don't get it, you're screwed, and you feel deflated, and then the new year starts, and you don't even know where you're going to start from. Like, we need to create a system that keeps going, so I know who to outreach. It doesn't end on December 31st. It just sort of kind of carries on. So I can, every time I'm touching that person, whether it's a phone call, whatever, I can move that needle iteratively, capture those gaps iteratively throughout the year without necessarily waiting for that one crack at it.
I think one issue too that you've identified, Karthik, is just like these lists. Like, why do we have these lists? Because we don't have the data that appears in front of the PCP to know in that moment, these are all the things that I need to or should be working on. And it's not fair to have to do it all in one shot. This concept that the AWV is going to be able to sort of hit all of your quality metrics, also like decrease your costs, also do, like, it is, and then let's say you do code 30 problems. Well, the billing company only accepts 12,
Yeah.
right? You can only submit 12 codes on a page, and if you're lucky, you've got to practice with a small billing company, and it's a guy in a hoodie in the woods of Vermont who only submits 4 because that's all you need to get paid for your CPT code, right? And so there are, like, every step of the way, there are issues with, like, actually really knowing what to do for the patient, and we aren't patient-centered in VBC. We don't actually look at the patient in front of us. We're doing things to patients, not for patients. And I think at the system level too, it trickles down to, like, oh, this PCP is a bad performer. This PCP is doing a really bad job. This PCP is bringing down our ACOs quality metrics, but we don't actually always know why. We don't actually know where those gaps are in the practice. Is it that there's not enough staffing? Is it that the technology is old? Is it that the PCP actually, like, I would say very rarely is the PCP saying, like, I don't give a bleep. I don't want to take care of, I don't want to do these metrics. Like, I would say most people who went into primary care medicine, like, want to do right by their patients, want to do well, but the system doesn't, like, we give these lists because that's the limit to the data that we have, and we say, now you go deal with it. And that's sort of been the approach, is just this forcing of siloed data that doesn't actually paint the big picture, but we expect the doc on the ground to actually, like, be able to consolidate all of that information in a thoughtful way, and to actually, like, plan out, actually, I'm going to do an AWV today, but I'm going to bring the patient back in this amount of time, not address any of the social determinants of health that might prohibit the patient from coming in. And then all the financial misalignment, patient doesn't want to come in and pay another copay. The patient doesn't, right? And so there's a lot of disjointedness, and we're all sort of trying to do our one thing. And the fact that we give you a list, Karthik, that's like, here's all your cancer screening, but then we're going to give you a separate list for all of your diabetes metrics, and then we're going to give you a list for all of your, like, this is your ED.
All 3 lists.
Right?
Yeah, there's so many Excel files. I mean, I could just write lists on it. It's insane how many CSV files I have. And it's to be honest with you, you make that list and you send it to me, and I don't open half of them because I can't. So it's what it is.
Right, because some of the practices don't, I mean, not in your case, Karthik, but there are some practices who are still emailing patients on their Hotmail account, and it is not HIPAA compliant, and it's like the infrastructure there, especially in smaller private practices, I think, isn't there. But the thing I want to point out, though, at least at Metro West, the private practices actually were the best performers in terms of total medical expenditure, right? So they maybe didn't get every single post-discharge follow-up, like they didn't get a 7-day after inpatient admission visit in, but their rates of readmission were not as high, and they don't cost a lot because there's a trust, there's a relationship, and we have sort of, primary care is sort of fractured in a lot of ways as we pulled it, and that's a whole nother conversation that we don't, like urgent care, telehealth, all of that, like, but the trust that we need between the clinician and the patient has completely eroded in some ways. And so the practices that really do well, I think personally, are the ones that have the strongest trusting relationships, because they do call the doc when something's wrong, and they have the trust to be able to say something doesn't feel right, or I found a lump, or I just don't feel good. Or you have that relationship to say, like, Mrs. Jones, you just don't seem yourself this time around. Like, what else is going on? And so, again, I think this segues into, Mark, like, where does technology fit in? How do we enhance and enable the primary care doctor to do the things that they need to do, both what they want to do and what the VBC expectations are as well, and to sort of redesign the way we do primary care?
Exactly. And so this kind of gets into like a delineation between two things. I think that right now there's a lot of, let's say, like efficiency like coded AI, right? Meaning like functionally what people are looking at and saying is like, hey, how do we enable people to do their jobs more efficiently by giving them AI to like supercharge their workflows and like do that, right? And I think that is good in a lot of ways. But the challenge usually is, let's say like there's a bunch of businesses that are building AI receptionists for like primary or for whatever other subspecialty. And it's like, there's two problems. One is that most of the time, the tech is built such that, sure, it might take the call, but the way that it gives it to the front office staff, for example, like it'll basically be a handoff to that front office staff. And now it's like, potentially added more work as a function of it could be a net negative, because, for example, let's say the AI picks it up, goes back and forth, and gives like a summary of that conversation to the front office staff, which is like a bad summary or not a useful summary. And actually, it might have been better if the patient had just called and left a voicemail. That it's like a case in which it could be a net negative overall to the beyond like the patient's experience, but also to the practice. And the challenge is that like there's a lot of businesses right now that are kind of promising the efficiency layer, which is, hey, like we're going to come in, we're going to help you by giving you these tools that make you better and might require you to change your workflow in order to actualize the benefit, but like it'll be worth it, I promise. And I think that is okay. Like that's fine. I think what is now possible is that the pitch could actually be, hey, like change nothing, don't like do anything. We'll like own this entire workflow and get to the outcome. And the question is like, what is the outcomes that we're trying to orient towards? And we talk a lot about this specifically because like in an age where there are like AI agents that can use computers in the way that a human can, you can actually, instead of saying like, hey, practice, take this front office call, or rather, here's an agent that will take this front office call and like maybe give it to your front office staff in a way that's like not super useful and potentially is a breakdown in communication. Instead, take this front office call and this patient wants like to schedule an appointment or wants a refill or wants a like i.e. a prescription refill or like a referral request or prioritization, whatever it is. And then go and do the atomic actions on top of that that are necessary to get as close as possible to the outcome as an extension of the practice, right? So like in the case of scheduling, it's, hey, take that patient's information, especially if they're a new patient, figure out what time slots work best for them, use one of these computer usage agents that'll go and log into the EHR, get to a sense of like what actually slots work, push that as a scheduled appointment, and then it's like, oh, interesting, you have now made the economics to be able to deliver that outcome much more beneficial for both the practice and the patient. And two, what you've done is you've added no additional burden to that practice. And you can take, when you take this mindset to every workflow, things start to get interesting, right? And so like, I'll kind of like leave that as the kind of generalized context. And then we can kind of go from there in terms of what workflows is potential, or how we can like change the workflows that we currently do to better reflect that, because I think there's a lot of examples. So I'll like hand it to Karthik first, because I know we talked specifically about this a lot. So like, go for it. Go ahead, jump in.
Yeah, I mean, and the other downside to efficiency AI is you are going to asymptote fairly quickly, right? It's like risk coding, right? You figure out how to do it, and you do it, and you're gonna like maximize that because you've made the humans a little bit more efficient, right? But then what you're still gonna asymptote, right? Our healthcare system has still significant amounts of gaps. So what is ideal is one where like, and it's not going to happen overnight. It's like, how do we redesign the whole process? Let's just take that phone agent, right? Traditionally, somebody's going to call my office, probably call my office right now as we're speaking. They need an appointment. They're going to take a message and do whatever, right? Okay, right? Your system, your AI can grab that data, do all that stuff. But let's think about it from a larger context. This agent is also going to be able to log into my system, right? This agent can see my care gaps that have been filled into my EHR, that when they come in, I'm capturing. They're like, oh, you're coming in you have a cold. Hey, by the way, looks like Dr. Ravindran, put in a referral for a colonoscopy. It didn't look like that gap got closed. What happened with that? And maybe they will be like, screw you, I'm not going to talk about this, I feel like crap. But they may be like, oh, I forgot about that. Let me, and then your agent can do that, right? Like you once you've trained it, you can take it to that next level. If it didn't call for an appointment, they're just calling, I don't know, they just need a refill on their lisinopril, right? Now your agent can be like, okay, looks like your lisinopril, we'll tee it up, but it doesn't look like you have an appointment with Dr. Ravindran. Let's schedule that. Let's see if we can find a spot for that. Or even if it's a televisit, just to check on your blood pressure. It's been a year and a half. He doesn't have any idea what your blood pressure is actually doing. So let's just make sure he does it. Or they're diabetic and they need an A1C ordered. It's like, oh, look, you don't have any appointment, Dr. Ravindran. Maybe let me tee up an A1C. I know what lab you went to last time. I'll send it over to him and then he can send it out and maybe you can get that done. And, he'll also send over your, I don't know, whatever, your Ativan or something, whatever it is. So it's just,
Probably not the control.
Oh, yeah, exactly. Whatever. Yeah, hopefully non-controlled. I don't know why that's the one that popped in my head. But I guess my point is, you're now unlocking more out of what you can do already, right? So then this allows you to redesign your staffing models, which then allows your practices to maintain better margins, which will then allow them to, not go out of business, right? So I can actually elevate my staff to levels where they can supervise these agents and make sure that the outcomes are going where they need to go, not be the one that physically has to do all that, refill this, refill that, or schedule that, or look in the chart, right? Like that stuff that is, even my staff can do that next level. So then I'm hiring fewer staff and they're also working at a higher level. So then I'm getting more bang for my buck, reducing my margin, or increase my margin, I guess, and allowing me to also provide better, more integrated care. Like, and the patient feels that they're known, right? Like, because they're connected, it's not just, oh yeah, I'll take a message. It's like, oh yeah, that person has a gap. How do I address it? And they feel more engaged with that practice. The practice actually knows knows me. It's not just, oh yeah, I'll just to get your information and we'll see, right?
But we aren't quite there yet, right?
So I'm not saying we're there yet. I don't know. This is aspirational.
Yeah, this is like. I mean, I think the scheduling one is an interesting example. I think that's probably what first popped into your head, Mark. I mean, scheduling is its own beast because I think right now you don't even need the agentic AI. Like people can schedule themselves when like on Epic, you can we are automating and leveraging sort of algorithmic AI already to optimize scheduling. But I think, all of the steps that Karthik sort of mentioned are where we want to head. And I think you started to go down this path about sort of optimizing staff. And I can say at a larger level, whether it's an IPA with resources or a clinically integrated network, I really do think that the future of value-based care, when we really talk about total cost of care and efficiency, is actually team-based care. And right now we have a community health worker reaching out for social determinant of health. We have a nurse care manager who's doing a transition of care call on behalf of a practice. We have a behavioral health support person who is navigating someone to their behavioral health provider because it's just so hard and the PCPs don't have time, right? How do we, I do think that there is something to be said about, Karthik, you said, to be seen. How's a patient seen? I don't know that our AI is like there yet, that they can actually know the patient, but that human component of enabling your staff to potentially pick up a phone, not have to deal with scheduling, know the patient, know what the gaps are. And so right now on the like ACO, IPA, SIN level, we have these care teams that sort of are each doing their own part. But where we don't do a great job necessarily is aggregating all of the data and sort of optimizing the teams in ways to remove the, I don't want to call it scut work, but I think, the transition of care, like the TCM, could you automate that one piece of the telephone note to make contact with the patient, to put a note in the chart, to actually review the meds and ask those 4 or 5 key questions that are required in documentation for a TCM that then enables the doc to actually see that patient. And perhaps there's AI navigation to check in, just confirming that you can make it to your appointment within that 7-day or 14-day post-discharge window. And then when they come in, the note is sort of ready to go. And it actually, because the issue with the TCM is the not submitting the claim after you see the patient. So what the system focuses on is like, did the patient go in and see the doc? And they don't realize all of the other operational things that are required to billing a TCM, which means PCP needs to hold the claim. You have to wait the 30 days that the patient goes back in. Who's going to manage that Excel file of these are all the patients that I saw for TCMs, and then I'm going to hold the claims and submit the claims once I know I'm 30 days clear. Like all of these, it's just death by every single like procedural issue. Yeah. But if we can leverage technology to manage that like somehow it goes into the computer, that like, into the system, and they know to hold the claim, and they know to watch the ADT feed to ensure that the patient didn't actually go back to the hospital. So it's all of those components that if we could automate along the way would really make the doctor's life easier.
Yes.
The provider's life easier. The patient doesn't know. Things are seamless to the patient. They think the doc is great because everything's worked smoothly,
exactly.
Right? Like it's a win-win for everyone.
Well, and so one thing, and then wait, Karthik, I'll let you jump in. Just like one thing that I think is like maybe additional framing. It's like it seems like we're talking about 3 things, right? One is like the data on these populations and understanding where that's housed, how to get it, and how to use it. Right. 2 is like the workflows on top of that need to be executed that require certain like scut work that otherwise is really, really challenging. And 3rd is, I think, the aspiration of where that can go, assuming the first 2 are done, or like assuming the first 2 are possible. And so just to like ground additionally, it's like, well, right now, for example, and we've talked about this, like every primary has a different EHR that is configured a different way, that is the source of truth, but every aggregator out there has a 90-day claims delay lag. And it's impossible to figure out what is actually going on with this patient in the moment. It creates a lot of friction for the practice because from the physician's perspective, it's like, how am I going to use, like this list is actually unusable. Yeah. And so the question is like, okay, well, interesting. Is there like a world in which we can push information into the EHR and pull information out, right? That's like the first set of workflows like on data, right? Because then once we can use the EHR as a leverage point to get all this information and figure out, to your point, it informs what are the overarching workflows that we can orchestrate to get to the outcome that is best for the patient. In the case of, let's say, for like a patient who has a quality gap, there's like 4 situations that could be happening. One is that like the doc missed it, which may or may not happen, like it's reality, that's fine. There's not much that, I mean, there's like a piece that can be done there. The second is that the doc did their job, the patient forgot about it, in which case somebody needs to own that workflow, reminding the patient, trying to figure out how to schedule that patient for that colonoscopy or for the diabetic eye exam, etc. It's 3 that the doc did their job, the patient did their job, but the place and site of service that they went and did it at didn't send us back the record, in which case we have to figure out how to reach out to that office and get it done. Or it is that like the actual site of service did their job, but like the record of it is sitting in a fax inbox that we didn't check, right? In all these cases, it relies on these workflows that need to take place that may or may not actually be taking place. And the question is like how you can put as much of this on autopilot as possible and figure out what are the atomic actions that actually need to take place in each of these workflows. You know, and so Karthik, I'll let you jump in there just because and use that as like a little bit of grounding.
I mean, you brought up the fax inbox. I mean, like a couple weeks ago, I had 800 faxes in that fax inbox. Like, and there's data in there, but it's all like these PDFs and random this and that, and then there's all these other stuff that's probably not even useful. But how do you train the system? Because like, you know, right there's a mental construct by which like my staff member goes in, will attach it to really low end stuff, like attach it to a patient, hit the button, and it'll attach it to the patient. It'll go into my inbox, and then now I'm looking at it, I'm perusing it quickly for, you know, clinical nuggets, like, oh, there's maybe a diagnosis code that I'm going to throw my problem list, so the next time they come in, I'm going to like do it. I'm going to make a note so I know it, whatever it is. So there's a process, right? You can train the system. Like the first part is easy, right? It's just fairly mindless, right? You're just like clicking a bunch of boxes to get it into the right patient's chart. But I'm using my patient, my staff members.
I don't know. What I was saying is that like today, in the today state, like having agents do that is actually already possible. And like we're showing that like that is the okay, clicking through the buttons to get to that at least first outcome is a possible thing today. And then now continue to your segment.
I mean, when I was at Tufts employed, they had one person whose only job with benefits and, you know, 401ks to just deal with the fax inbox for the 6 providers there. That's
Oh no, we dropped Karthik.
It happened.
Mark, did you do that?
I did not do that. I did not do that.
Did you pick him?
Well, we're working live here, folks. So we'll wait for him to come back on. But
Garrett, why don't you text Karthik? There he is.
I wanted to switch my microphone. Maybe I'm just.
It was.
No, we're good. We're good.
The ball was out to get you. Okay, continue, Karthik.
I don't remember where what's the last thing you guys heard before I dropped in.
The last thing you said was there was specifically a person dedicated to just doing fax inbox.
And so, right, like that's all they did, right? It's not, and they're just attaching it, right? And they're not even taking that, helping me extract the extractable, useful data that I can then take forward, right? Like if I know this person has, let's say, CHF, right? And I've not put it on my problem list, or maybe it's a new diagnosis. If that data, like, you know, if there are certain prescribed things that can be like extracted and put in a place where I can see it, right? Like it doesn't need to be, it's not going to go into and billing claim necessarily off the bat, but go somewhere I can see it. So then when I see them, I'm like, oh, you have CHF. Oh, you're not on all the goal-directed therapies. You're not seeing, like, what's the story, right? Or maybe the aorta is a little bit bigger than it should be. We need, like, that should prompt me to do that, but it should be done like without me having to go in, spend the time, read through all the stuff, the demographics, all the stuff that comes in, to pull that one bit of data.
And if they're not on the goal-directed therapy, i.e. statin use in persons with diabetes, then the exclusion reason why should be pulled in automatically so that you actually get pulled out of the metric. Or if you've had a bilateral mastectomy and the quality metric gap is open, like I jokingly always say, like the breasts don't grow back every year, right? So like, why are we playing this?
Well, having to like. And then I can only get 12 codes out, so then I have to use up one of those spots on that bus to put in that bilateral mastectomy just to make sure that the breast didn't grow back or that cervix didn't pop back in there.
Right.
So, like, in some ways, there are certain things that could be, like, you know, if you have the data, you know that cervix is not there in 2024. Unless by some miracle, it ain't going to pop back in 2025. So just carry that code, permanently exclude them from that without me utilizing one of my 12 spots to get that, to capture that code, right? Then that's one less code, risk adjustment code. It's also one less thing I need to do, and I can focus on the bigger picture. But, you know, but the fax inbox is just one of a million different things, right? The front desk, fax inbox, billing strategies, like all of these iterative pieces that coalesce into a larger, you know, what is it, problem or whatever, that slows things down just across the system, right? Like just basically makes your whole practice very constipated and things just don't move the way it should. And how do we get things going? How do we add, you know, the laxative to make things move nice and smoothly to really, really make things happen fast?
Well,
I've had a lot of coffee,
right? Yeah, these analogies are really crushing it today. But it's becomes a death by 1,000 cuts, because then you're dealing with all of these small. So there's two of them, like types, right? One is like the mindless, actual clicking of buttons to move things around in a way that gets to the clinician, frankly, or the physician. In this case, for example, with fax inbox, like we're sitting on 800 messages that requires literally somebody to just sit there and click 5 or 6 buttons to get to the ideal outcome, right? Which is it's in the patient's chart. Therefore, like in the case where a lot of the records are sitting somewhere, now at least they're in the patient's chart so that we can do things with them. And so that's the first step. And the second, and I guess additionally to that, is like, can we lift that information and put it somewhere that actually makes sense? The second is actually like, how do we then get the reasoning steps, which is, oh, okay, like what are the things that need to happen next, which becomes super, super interesting. I think that's a more long-term frame, but like the first step of like, okay, well, how do we just get an agent to click on these buttons to get to these tasks, like to get to this individual outcome? That is becoming more and more real and like more and more possible. And I think that's where things get really exciting, because then you can own that workflow layer and start to do things that get to actual outcomes instead of saying, hey, like have your staff use this tool that maybe it has to create a new workflow that exists and and like maybe makes it more efficient by like 30%. Instead it becomes like, hey, have your staff actually focus on the thing that matters, and maybe it is actually like the clinical decision support on top of that, or it is the actual output, what the output unlocks, which is here like the 3 things that we have to do with this patient, and like maybe we want to have a staff member manage that, because it's like a lot of that work right now, a lot of that second order like work that allows for practices to deliver almost like concierge-like experience at scale becomes almost impossible when dealing with client service for 2,000 people or 3,000 people or however big your practice is. It becomes functionally impossible. And so, yeah, Jenny, you had something to say though. I want to make sure you get it.
So many things. I mean, I think the reality is, for providers, for doctors, for NPs, we just want to take care of people, right? And I think whatever the future state is, because right now we're fixated on risk adjustment. What if they get rid of risk adjustment? Like what if you get down to the basics of how do we enable people, humans, our patients, to live their best lives? That is really sort of, if that's the North Star, what are all the tools that we need in place to enable a patient to live their best lives? And I think that includes not spending money. I don't know any patient. I mean, the statistics in Massachusetts are just like gut-wrenching. The average family in Massachusetts, I think, spends $26,000 a year on medical costs. Like that's a new car every year, right? The current trajectory of where we are going does not seem to be stemmed by any of like the ACO work, Pioneer, NextGen, MSSP, Reach. Like all of this is sort of, we keep the VBC contracts, the guardrails keep getting bigger and taller and higher and stronger, and yet we still haven't been able to cost contain. And so how do we empower primary care doctors who are on the front line to enable patients to live their best lives? Like, when can we get to a point where we all agree that it's not acceptable for someone to go to the hospital with a heart attack? Can we not all agree that like we know what we should be doing? And again, getting the patient to do what they need to do is not always easy, but like when we talk about IP per 1,000, inpatient admissions per 1,000, or ED visits per 1,000, like they're just numbers. We've gotten to a point where like systems are just like, okay, well, this is our rate, it's X hundred per 1,000, and how do we lower it by 10% to prove that we're moving the needle so we can get paid more? But like, if we could all get to a place where it's just not acceptable the way we're delivering care right now, and how do we actually make things easier for patients and get the right care, is how we empower that PCP. And we've had conversations fantasizing about like leveraging the AI to really help you get to know your patient in that single moment of like, Karthik, you're sitting with the patient and the AI is telling you that like, actually the predictive analytics of this patient developing kidney disease in the next 5 years is this, and maybe we should get them connected to an RD who can talk about their dietary changes they could be made. Like we're not able to leverage all the resources in the work that exist right now. And there's going to be a bigger and bigger divide between those who can afford concierge-like experiences because of volume, right, over like this massive expansion of like, the solution seems to be, let's just hire hundreds and hundreds of APCs and give them AI tools to, right? And I don't know, I mean, I think there is a huge primary care shortage. This is a whole nother talk we could have around sort of the death or non-death of primary care. But I think in the confines of value-based care, what are the direct things that we can do today that will maybe make our performance better, maybe make the PCP's lives better as we sort of inch towards that.
But take one step back. So like as a PCP, things that are going to keep my longevity as a practicing provider are things getting stuff like the fax inbox off my plate, getting like onerous screenings that I will have to do in the office. You can feel my shoulders tense up as I have to kind of do it. So what we need to do is identify all of these different small pieces that can be offloaded, because the dream state for me is where I walk in the morning, I haven't prepped anything, I wake up late, I roll in, and I'm there. I don't even know who's going to show up that day, but the moment I open that chart for that person, I can see what they will need. I have some predictive data based on prior things. I kind of know the chart is auto prepped to the degree that I can auto prep. So then I can just sit down, have a conversation, and then the auto scribe will basically document properly, not just document just like an urgent care note, but document to the coding that necessarily needs to be done, based on the conversation. And then I'm going to generate a plan. I'm going to tell the patient, this is what I need you to do. This is a plan going forward, and it's going to generate that education material. And then this AI agent that's hanging out next to me is going to then put in all these, as I'm speaking, put in all these orders. I'm going to sign off on it, and then it's going to close that loop going forward to make sure that person gets it done. So I basically am done. I feel good. I've done it. I've been able to actually look at them in the eye and not be staring at a screen and have a conversation, and everything is done on the side. And that would be ideal, because then now I am doing what I trained for, why I went into primary care, and it makes me feel good. I am less likely to burn out. The longer I last, the less churn and burn that exists downstream. And if you can scale that lack of attrition, I think you can slowly rebuild primary care to some degree. And as you augment it with all of these other solutions, because you need a multifocal approach. And I think that's where the promise is. There's so many small pieces that can be done, because the pieces are so finite and so mind-numbing, but it does just slowly just chop you, cut you by whatever 1,000 cuts or whatever the analogy is, 1,000,000 rocks or whatever.
Yeah,
and at the system level, similarly, at the system level, how do we aggregate all the data? How do we leverage sort of realistic insights? I think a lot of this is we already have, there are companies out there doing this, right? Like, how do you pull the data in a thoughtful way? How do you use AI to scrub it? How do you then curate how do you build that sort of patient picture in front of you? But again, those are all driven by the VBC constraints. They're not necessarily driven to put the patient at the center and to actually enable them to live their best lives. And so if we could sort of elevate that to the next level. But right now, that's future state. Right now, it's really about how do we get clean data? How do we organize the data in a thoughtful way? How do we actually collect that data and present it in a way that a doctor will believe it, right? Because Karthik is very, very trusting, and you're probably on one end of the spectrum of like, yeah, just give me all of that AI data and I will just coast through my day. But you've got a lot of docs who don't trust it, who trained in a certain way, who are like, who say like, the AI is not good enough. The AI can't actually do those insights for me, right? And so until it gets to that point, and it may never get to that point, because the level of complexity that like as a geriatrician, patient comes in, social determinants, it's not just about diagnosis, but how do we start leveraging right now appropriate data insights, getting them to the doc in a timely way, connecting the docs to the systems, right? It's not just like Karthik's PCP practice, but it's how do you get your data back to the bigger system, because that's where we struggle. We clinically integrated networks push data out, they give lists, but we don't always get the data back. And I think CMS is headed in this direction, right, with the ECQM metrics. So how do we sort of, at this moment in time, close all of those minor gaps? And then how can we start supporting the patient in ways that actually don't necessarily require more FTEs, right? So agentic AI patient navigation, text messaging, outreach for patients, checking in with text message platforms, providing outreach, providing education for the patient asynchronously in whatever modality is the best for the patient. We've got to start broadening this. This is a term that I didn't know as a physician, but like your omni-channel approach, right? That's one approach to how do you contact the patient and connect with the patient in whatever methodology they prefer. I would say our older Medicare patients may not necessarily be what our Medicaid patients are looking for, who are on their devices all the time. So how do we really understand the demographic of patient that is in front of us? How do we tailor those interventions to those patients, to those cohorts in a way that's meaningful? And then how do we actually collect the data after? Because right now we're pushing text messages to remind people to come in. We don't always know if the text message was open. We don't actually know if the patient made an appointment. We don't know if they came to the appointment that was scheduled. So again, a lot of I think the technology is about being able to track and monitor what you're doing. And exactly. I do think the future of value-based care really comes down to the playbook isn't going to work anymore. There's not a single solution, because everybody's practice is so different. So how do you become more agile to design for this practice with 6 PCPs need these interventions, but this practice with 45 employed doctors need these interventions? And how do you leverage what exists in those frameworks? How do you optimize? And I think that's probably the first place to start, which is looking at what the model is today and where are and like Karthik's end state of like every single tiny little point that we can optimize with AI, we could get to, but recognizing that not everybody necessarily wants that.
Agreed. Well, so I know we're almost at time, and I want to maybe make one final point, and then we'll go to questions, I think. But I think that we're going to do is now, like in real time, I'm like, man, we should do a secondary talk on like, we did a good job. I think we did a really good job just framing.
We should get feedback and confirm we did a good job first, Mark.
I think no.
Like we're just
like he's done a good job. That's enough.
No. We'll ask Garrett when he comes in. But like I think what we did a really job at was framing overall the problem, talking about how things are actually being done, what the problems are in doing those things, potentially aspirationally what we want to get to, some of what's possible. And like wrapping up on, okay, this is like what needs to get done to make sure that patients get a relationship with their primary care doc in a way that makes sense for them, and that primary care docs are able to alleviate or offload as much of the laborious work that is necessary to be able to deliver that, and these like tiny points and workflows that are required. I think that like what may actually be a great talk for next time would be, okay, well, that's all of that is super helpful. And also like show us exactly what is possible today. And I think that would actually be pretty cool. Like Karthik and I are going to do a really long discussion on Wednesday or Friday rather about that. And so I'm just like teeing that up in the immediate term.
I can just quickly say one last thing though. In reality, in our practice, Mark is already building some of these things. So, patients that like this one is an MRI right now. So I ordered an MRI. The authorization was taken care of on the side. My staff didn't utilize anything for that. The order got there. And actually this is another patient where the MRI, like in that morning, like needed I forgot what that patient needed, right? Like there was something, and you messaged me quickly at 7:30 in the morning. It was something I needed to do. It was sent, and you coordinated that care, like your system coordinated that care for that patient to get that MRI done that morning. I just put the order in. I didn't even I don't even know what happened all in the back, and everything just kind of happened. And I got done. But that is a microcosm of the bigger thing. Like each of these are micro actions that have a same general life cycle. There's an initiating point, there's a action that needs to get done, there's all these processes, and then there's a loop closure that needs to do to then extract that data. And so far we started to build some of those things. There's still a long way to go, but I think some of those things, there's a lot of promise. I think that's one of the really exciting things about practicing medicine.
Target-rich environment. Agreed. Okay, Garrett. I know that we're at 6 minutes and 15 seconds, so go on.
Yeah, no worries. Okay, so we do have time for a little bit of time for a couple audience questions. Well, maybe some very brief ones. If you have a question, because there's good chance we won't get to yours because we've got a lot of them. Go ahead and drop yours in, though, to the question module. We're going to get to as many as we can, but someone will reach out to make sure your question gets answered. So go ahead and drop that in. But real quick, if maybe you guys could give a really high-level answer to, or a quick answer to, how do I make sure that AI doesn't take me out of the equation? How would you handle that question?
It won't.
So-
I don't think in healthcare the patient's ever gonna not want. I mean, I don't know who me is, if it's a provider or a clinician, but I think all humans we could be leveraging all of our humans better, and the AI is really just the technology to make the job better.
And I would venture to say, I agree. I think what it does is it opens up, because there is no replacement for that human interaction yet. There's patients that are more complex. They're not looking for like a for him's answer, right? They're looking for an actual, I hope for him's, but they're actually looking for somebody that's going to talk and listen and just can engage with them on their issues, right? Now, simpler things, if you offload those things, I'm actually going to be more available for you, and that bond becomes stronger, and that bond transcends temporally. And as they become sicker as time goes on, that trust that develops allows us to engage on more advanced things that will really save money. Like, right, if they trust me from day zero and they know I'm going to listen, they're more likely to engage with me when it comes to, advanced care planning and MOLTS and DNR, DNI, things like that track toward the end of care that generate quite a bit of cost. So I would say that this is only going to make me better and allow me to be more present and actually add me more to the equation than it would otherwise.
Exactly. Yeah, and that is exactly how I feel too. It's like generally most of the time, the question really is how you just facilitate the doc to give good care to their patients, and that's what matters, because walking backwards, everything else is not a good use of their time for the most part. And so how do we enable them to scale themselves to do that? And I think that's like where the game is.
And if I burn out and I leave, then I'm already taken out of the equation, right? So
exactly. By default, like at the back rank, like if you leave, then that's the conversation is just not work.
Oh, well, cool. Well, unfortunately, we are out of time. We've had a fantastic discussion today, and we do have, again, some other questions, but if yours didn't get answered, don't worry, someone will reach out. But I wanted to thank you all. Mark, thank you so much for helping put this thing together. Dr. Chiang, Dr. Ravindran, this was a wonderful discussion. And there's going to be just for you all out there, there's going to be a survey that pops up. If you would like a part 2 of this discussion, let us know. And we might be able to convince them to come on back, and we can do some other topics or an add on to this one, or we'll get Mark involved.
Mark's already said it's good, so
yeah, but thank you again so much, guys, for a fantastic presentation. I know I learned a lot. I learned not to trash talk fax machines, otherwise it might kick me off of whatever webinar I'm on. If that's what's happening. But no, thank you all so much, and thank you, audience, for joining us. Mark, if I could get you to pull up the final couple slides here. I wanted to encourage you all to, as we close out here, to head over to vbcexhibithall.com and check out the Beacon Health virtual exhibit booth. And Mark's about to put, there it is. There's a picture of it there. There's a lot of great material there that you can read up on them, see what they're doing in the space, educate yourself a little bit, and of course reach out to Mark there and the Beacon Health team, and then he'll be able to kind of point you in the right direction. And then finally, if you would like to reach out to Mark directly, his contact information is here on this last slide. And you can either call him or text him or whatever, give him an email, or if it's easier, I'm happy to facilitate an introduction as well. So feel free to reach out to me. Thank you all again so much. Hope you have a wonderful rest of your day, and join us on the next discussion. Bye bye now.
Yeah.
Bye.
Bye bye.